ان شاء الله تكونوا شايفين السكرين بتاعي ان شاء الله. شايفين يا جماعة؟
يا دكتور.
طيب
السلام عليكم دكتور إيهاب، ازي حضرتك؟
الله يبارك فيك. بالنسبة ماي نيو يوتيوب شانل، طبعا لسه ما بدأتش حاجة، لكن يعني it will be إن شاء الله a good site for posting important lectures. آه الأول طبعا هنبدأ بريكوردد فيديوز ونبقى نقول لكم عليها وميعادها. وزي ما انتم شايفين اسمها نيو ليرن with دكتور إيهاب أحمد. and this is the link اللي تحت دي لو تحبوا تنقلوها إذا كانت واضحة. آه أوضحها أكتر.
ممكن حضرتك تعملها كوبي تحطها في الشات يا دكتور؟
ها
ممكن حضرتك تعمل كوبي لللينك ونحطه في الشات؟
حطها في اللينك ونعمل
كوبي،
لك.
حضرتك تعمل كوبي
ادي كوبي اهو، كوبي وبعدين نحطها فين؟
في
على
الشات.
الشات.
اه.
شات اعمل لها بيست مش كده؟
تمام يا دكتور.
مش عايز تو يس everyone.
طب خلاص هحطها هنا يا دكتور، حاضر.
خلاص انا اهي احطها اهي بيست اهو، اهي موجودة هنا اهي موجودة.
هي ما ظهرتش عندنا لسه.
أهو. طيب انا هحط ايه؟ هحط الاتنين مع بعض ماشي. الاول دي
تمام، انا حطيتها في الشات يا دكتور، خلاص.
خلاص ماشي. وبعدين برضو نحط اسم الشانل،
تمام، حاضر.
نحط اسم الشانل والويب سايت بتاعتها. ولما تبقوا مستعدين نبدأ إن شاء الله.
تمام، دقيقتين ونبدأ بإذن الله.
نبدأ.
تمام، اتفضل يا دكتور.
طيب بسم الله الرحمن الرحيم. We will start today with discussing some MCQs. Number one is a term female infant is born via C-section because there was placental abruption. These are keywords: placental abruption and term. Resuscitation is required after birth. Apgar scores 1, 3, and 7. Apgar was very low initially at 1 minute, slight improvement at 5 minutes, some improvement at 10 minutes. But the baby was depressed. After delivery, we noticed that the urine output remained low, between 0.2 and 0.5 milliliter per kg per hour. What is the normal or the minimal amount of urine output for a newborn baby in the first 24 hours? If you know the answer, you can write it down. So this baby had low urine output, between 0.2, 1 to 2, no, and the minimum, no, yes, Dr. Sarah got it, 0.5. 0.5. But it depends also on the age, by the way, as we are going to see. So low urine output, this is a key word and a very concerning sign. So they did renal ultrasonography with the Doppler, and it revealed hyperechoic appearance of both kidneys, but there was no hydronephrosis, and there was moderately decreased perfusion of both kidneys. Decreased perfusion of both kidneys. Kidneys were having a hyperechoic appearance, but no hydronephrosis. Babies having low urine output, oliguria, and baby was initially depressed at birth because of the placental abruption. Maybe the baby and the mom or one of them lost a lot of blood. And this is shown by the low Apgar score. So what is going on? What is going on with this term baby? What is the problem? What are we dealing with? Say it again.
AKI?
Yes, we are dealing with acute kidney injury or acute renal failure because of the neonatal depression. On day 3, the infant started.
مشغل المايك ممكن يطفيه.
Please mute everybody, please. On day 3, the infant starts.
دكتور إيهاب استاذن حضرتك تعمل ميوت.
And I got to mute. Okay, start again. On day 3, the infant started to receive intravenous dopamine, 3 mic per kg per minute, in addition to intravenous Lasix every 12 hours. Why they give dopamine at this low dose? We call it renal dose. You know, dopamine is one of the vasopressors that we use in case of hypotension. And we use it in low dose. It's called renal dose. It is presumed to increase the renal blood flow and improve the urine out. Lasix. Why they give Lasix? Do you hear me? Do you hear me?
ايوه يا دكتور سامعين حضرتك.
Why they give Lasix? Okay, we are going to see how we can manage renal failure or AKI. Then they restricted fluids after giving the Lasix to 60 milliliter per kg per day. On day 4, urine output is still going down, 2.1 milliliter per kg per hour. It went down to 0.1. So labs, the sodium was low and getting lower, 126 on day 5. Potassium is getting higher, 5.5 on day 5. Chloride is normal. Carbon dioxide is low. Meaning what? Meaning there is metabolic acidosis. BUN is high, eating renal shutdown. Creatinine is high, renal shutdown. Calcium is low. And we're going to see why calcium drops in cases of renal failure, why sodium drops in cases of AKI, why potassium goes up, why phosphorus goes up, and creatinine goes up and albumin is low. So why sodium drops in cases of AKI? I need immediate response to save time. Dilutional, yes, correct, because of retention of fluids. Why calcium is low? Or let's start with phosphorus. Why phosphorus is high? Because of decreased renal excretion, and this also applies to potassium. And because the phosphorus is high, we know that there is a reverse correlation between calcium and phosphorus. If one of them goes high, the other one should go down. So the phosphorus is high, so more calcium will combine to phosphorus, and there will be low calcium. So in AKI, you have to take care of all these electrolyte disturbances because they could manifest with serious manifestations like severe hyponatremia can cause cerebral edema and cause seizures if it's less than 120. High potassium causes arrhythmia and shows characteristic pattern of ECG depending on the level of the potassium. Metabolic acidosis is something serious, and they should have mentioned also the lactic acid. And maybe they mentioned it on its own. So acidosis is serious because it can affect every and each organ, mainly the heart, causing myocardial dysfunction. So the question is, of the following, the best next step in the management of this neonate includes. So before we go to the question, this AKI based on these labs, is it, and urine output and creatinine level, is it mild, moderate, or severe? What do you think? Mild, moderate, or severe? Severe, severe, severe. We'll see. Number one, the option number one, administration of theophylline. When do we use theophylline in AKI? PD, PD, PD. What does PD mean? Patent ductus? I don't know. Do you mean patent ductus? The use of theophylline in renal failure, it's for prevention. Once the baby is having manifest AKI, the theophylline is useless. And it is used in HIE. If you have a baby with HIE, then you give prophylactic theophylline trying to prevent AKI. So this is the role of theophylline. Continuous kidney replacement therapy. Is this baby a candidate for hemodialysis or peritoneal dialysis or hemoperfusion? Based on the following criteria that you are going to mention, we will know the answer for this option. C, no change to current management, and this is going to just by conservative management, the baby is going to recover on his own, or peritoneal dialysis. Which is your option? A, B, C, D, and Y. D. Everybody is D, but the correct answer is not D. We are going to see why. It is C. It is C. This baby is not yet a candidate for dialysis, whether hemodialysis or peritoneal dialysis or hemoperfusion, as we are going to see. No, we don't need peritoneal dialysis at this point, at this stage. Okay, let's see the pearls. About 20 to 40%, this is a huge amount of infants admitted to the NICU have some sort of acute kidney injury. So if you are in practice, you will notice this a lot. If 20 to 40% of all your candidates in the NICU will have some degree of AKI. Most infants with AKI respond to conservative treatment due to the reversible nature of the injury. Usually the injury is reversible, and only a low percentage will have severe and will need the kidney replacement therapy. And few amount of them will go into chronic renal disease. That's why AKI is something serious. It's very common, especially in preterm babies, and it is most of the time corresponds to conservative treatment, but if you don't take care of that, the consequences might be serious, chronic kidney disease. Okay, the infant in the vignette has persistently low urine output with increase in serum creatinine concentration, both meaning AKI. So there is nothing else that can do that except the AKI. AKI is a sudden decrease in the glomerular filtration rate and retention of nitrogen waste products. It is manifested by decrease in urine output due to inability to regulate extracellular volume, with laboratory evaluation revealing electrolyte abnormalities and elevation of serum creatinine concentration. 20 to 40% of infants admitted to the NICU will show signs of AKI. Keep this into the back of your mind. The kidney disease, there is something called Improving Global Outcome of Kidney Disease Organization. Divided the AKI into mild, moderate, and severe, or stage 1, stage 2, stage 3, based on this table. This table is, and will let us know if this baby was having severe or moderate or mild. Most of you said severe, but you didn't say why. Stage 1, the creatinine is more than 0.3 in the first 48 hours, or 1.5 to 1.9 times the baseline. If the baseline was like 0.1, so you multiply this by 1.5 or up to 1.9 in the first 48 hours. This is the lab. Clinically, urine output is less than half milliliter per kg per hour in the first 6 to 12 hours. This is stage 1, which is mild. Stage 2, creatinine will jump up to 2 to 2.9 times the baseline creatinine, and the urine output will be less than 5 cc per kg per hour for more than 12 hours. So if more than 12 hours, we'll go from stage 1 to stage 2, from mild to moderate, and the creatinine keeps rising. Stage 3, which is the severe, and creatinine is more than 3 and or more than 2.5 times the baseline, and the baby should receive dialysis at this stage. And in the severe condition, as in this baby, the urine output is less than 3 milliliter per kg per hour for 24 hours, or anuria for more than 12 hours. This is bad. This is serious. This is severe. Although most infants have transient, but about 25% might go to stage 2 or stage 3. And at this point, you have to consult the nephrologist, and you have to consider renal replacement therapy. I don't know if it's available, if you have available peritoneal dialysis or hemodialysis or hemoperfusion in your NICUs in Egypt or not. I have no clue. Causes of AKI, we know that it's either pre-renal, which is the most common, pre-renal. That's why management of fluids and management of blood pressure in a newborn baby, especially the preterm baby, is extremely important. Or intrinsic, and usually if the pre-renal is not treated, it will end up into intrinsic. So intrinsic is the acute AKI. And post-renal, which is very rare, like obstructive uropathies, so it's not in the case. So what happened in this case, most probably started pre-renal with some even intrinsic renal because of the HIE and hypoxia and low blood flow and low blood pressure and low cardiac output, and ended up in intrinsic AKI. In most infants, the primary cause is pre-renal, secondary to a decrease in cardiac output associated with hypovolemia and or hypoperfusion. Acute tubular necrosis is a complication of AKI if not treated, and this might lead to chronic renal disease. The risk factors include, I'm sorry, what is this? I have no clue. What is this? Risk factors: extremely low birth weight, sepsis, dehydration, perinatal hypoxia or HIE, or critical congenital heart defects. And we discussed in the lecture of critical congenital heart disease the impact of the critical congenital heart disease on the kidneys and how you should manage fluids and electrolytes and preserve the kidney of the baby. Patent ductus also, because there might be stealing of blood. If there is a left to right shunting, there is stealing of blood from the systemic circulation, leading to decreased blood flow to the kidneys. Other risk factors, nephrotoxic medications like the gentamicin and other drugs. Necrotizing enterocolitis and if there is ECMO. Acute kidney injury with impaired renal function may lead to disruption in electrolytes, as we saw, and we see hyponatremia, it's dilutional, can lead to seizures if not treated. Hyperkalemia can cause sudden death, cardiac arrhythmia. Hypocalcemia can lead to seizures. It's due to failure of vitamin D to act on the kidney and because of increased phosphate. And hypocalcemia can cause cardiac arrhythmia, can cause seizures. Metabolic acidosis, which should be treated, is due to failure of acid secretion. Hypervolemia caused by decrease in urine output may lead to cardiac failure because this is a burden on the heart. And even pulmonary edema can occur and capillary leak, causing generalized body edema. Mortality risk increases up to 7-fold if the baby is having severe AKI. So the mortality is high if the baby is having severe. Most infants with AKI respond to conservative treatment because of the reversible nature of the injury. And don't forget treatment of the underlying cause. So when you have an intrinsic renal injury, you have to avoid volume overload by keeping the baby on the dry side. That's why they give this baby only 60 cc per kg per day. And you might give diuretics, but the loop diuretics is not going to treat. It's just you are enhancing urine output and by acting on the unaffected nephrons. But the affected nephrons will need some time to recover. We talked about the dopamine. Usually it's the renal dose and the effect is doubted. And try to maintain electrolytes. This is extremely important. Then this is going to be managed through managing the fluid and electrolytes given to the baby. And if the baby is having severe AKI, you might need to do kidney replacement therapy, including to prevent complications. And these are the indications of replacement therapy. If there is severe metabolic acidosis, bicarb is less than 12. If severe hyperkalemia, potassium more than 8. Hyponatremia less than 120. Fluid overload as evidenced by heart failure or pulmonary edema. Hypertension, not responding to medications. And uremic encephalopathy. The baby will become lethargic, irritable in seizures, and of course, inadequate nutrition. And peritoneal dialysis, which was one of the options, is a preferred method of AKI because it's relatively simple, safe, effective, and less expensive. And if it doesn't work, they do the hemofiltration or hemodialysis. And this is outside our areas of expertise. We need to have a urologist, and we need to have people who are experienced in doing the dialysis or the hemofiltration or hemodialysis. This is a pure nephrology issue. Very low birth weight infants affected by AKI are 5 times more likely to develop chronic kidney disease. Okay, which is something serious also. So this is the prognosis. Either the baby dies, recovers completely, or goes into chronic renal disease. Factors leading to chronic renal disease include a higher stage if the baby is like severe or moderate to severe, high peak serum creatinine. The higher the creatinine, the lower the worse the prognosis. Repeated episodes of AKI if the baby has more than one episode, and this might lead to renal damage, and prolonged duration of the AKI if this stays for a long time. So severity, higher serum creatinine, repeated episodes, or long duration of the episode. Reduced glomerular filtration rate and elevated urine protein to creatinine ratio can predict if you have a baby and still he's not doing well, but he's not still passing some urine, and the creatinine is not very high, you might detect early reduced glomerular filtration rate by noticing elevated urine protein to concentration ratio. This is important, and I don't know if you do this in your labs or not. So patients usually have hypertension and decreased volume and also microalbuminuria. So we have to follow up this baby for at least 3 months. Okay, so the correct answer was continue current conservative management. Questions, comments before we go to the next question? Any questions related to AKI? And as you see, the information given in these MCQs, prep and critique, you will never find in any other textbook or journal or any reference at all. And you see, just one question, just MCQ one question will make you know AKI by heart. You will know it in no time. You can read it in like 5 minutes and you are done with AKI. Neck is hypernatremia. Hypernatremia is an indication for renal replacement therapy. Those babies develop hyponatremia. So they don't develop hypernatremia. كمية السوائل التي يجب إعطائها في هذه الحالة هي كمية السوائل الاعتيادية. لا، مش الاعتيادية. Usually this baby at the age of 3 to 5 days will take about 150 cc per kg. But he was given only 60 cc per kg, which is the insensible water loss plus what the baby loses in other sources like urine or vomiting or whatever. So it is not the كمية العادية, it is a reduced amount because this baby will have hypervolemia, and you have to be careful because hypervolemia will lead to heart failure, pulmonary edema, and generalized edema. Neck and AKI, yes, neck like sepsis. In the neck, there is hypotension, hypoperfusion. The baby is very sick and has sepsis also. So that's why neck, if you have a baby with neck, he or she is very liable to develop AKI. Any other questions? I want to ask about your opinion about using bolus saline 10 cc followed by yes. Usually, the most common cause is pre-renal, as we mentioned. And if not treated, it will turn into renal or intrinsic. So what you do is you have to fill the tank and then try to empty the tank. So to be sure this baby is not dehydrated, you have to give this bolus. 10 milliliter per kg of normal saline, yes, and this is followed by Lasix. Okay, but be careful, giving boluses to extremely preterm babies is not something good. It could cause a lot of harm. So try to avoid it as much as you can. But if you think your baby is dehydrated, initially by losing weight, by having tachycardia, and don't let the baby go into hypotension, because this is a late sign of dehydration. If you think that, yes, bolus the baby 10 cc per kg over 10 minutes, and then give a dose of Lasix. How to measure insensible loss in the case? It depends. You can check your table and decide based on the weight and gestational age. There is no meter that senses that insensible. It depends on the surface area of the body, and the surface area of the body depends on the weight and gestational age. So look at your table in the book. Go to your book. There is no measure like a thermometer or insensible monitor that can measure it. Okay? Check the body weight and gestational age. What else? Okay, we proceed. And we talked about theophylline, it's for prophylaxis. Second question. A 12-day-old, 12 day, this is a very important key point, key word. Term, 24-hour history of poor feeding, 3 episodes of bilious emesis. Bilious emesis in a newborn infant is extremely a red flag. It's extremely a warning sign. Don't take it lightly. Don't take it lightly. Bilious emesis in a newborn baby should be very, very well investigated. What is the most common cause of bilious emesis in a newborn infant? Just one word. Okay. Sorry, I will modify my question. What causes or where is the pathology that causes bilious emesis? I didn't like any of your answers. Small intestinal obstruction, upper GI obstruction. Yes, this is the correct answer. Bilious emesis in a term baby, you have to rule out upper GI obstruction. Upper GI obstruction. All the other answers are not correct. So, bilious emesis. Then we ask ourselves, what causes upper GI obstruction? Here comes your answers like malrotation, volvulus. Yes. What else? What else can cause upper GI obstruction leading to bilious emesis in a newborn infant? You said volvulus, you said malrotation, what else? Yes, duodenal atresia, bravo, correct. And on physical exam, the abdomen is soft but tender to palpation. This is a very important key point. The infant is tachycardic, has a delayed capillary refill with a normal blood pressure. And I mentioned hundreds of times, if you have a dehydration or hypovolemia, the blood pressure will drop late. Don't wait for the blood pressure to drop to diagnose hypotension or shock. You have to use other parameters, and the most important, tachycardia and delayed capillary refill. Extremely important. So normal blood pressure does not rule out that this baby was in shock, like septic shock. An arterial blood gas demonstrates a lactate. You get yourself used to check lactate in every and each sick newborn baby because it's very helpful. And when we discussed one of our previous critical congenital heart disease cases, we discussed the differential diagnosis of high lactate. So keep this in the back of your mind. So, of the following, when we talked, we said, some of you said duodenal atresia, some said mid-gut volvulus, necrotizing enterocolitis, and pyloric stenosis. We'll go back to the question again and see the keywords. This is a term infant. They didn't mention if he's a boy or a girl. 12 days old and only history of 1 day. Poor feeding, bilious emesis. Abdomen is tender, although it was soft. Baby is shocky, and lactate is extremely high. So the baby is very sick. This baby is very sick. So, what do you think? Is it A, B, C, or D, and why? I see duodenal atresia. I see volvulus. Okay. The B, mid-gut volvulus. C, necrotizing enterocolitis. Okay. Why it is duodenal atresia? Why it is duodenal atresia? How does duodenal atresia present? Does it present at day of life 12? So the baby will have duodenal atresia for 11 days, and then for some unknown reasons will become symptomatic. So you still go with A? It's not A. C, is it necrotizing enterocolitis? This is a term baby. Term baby. And has bilious emesis. But in necrotizing enterocolitis, number one, it is a disease of preterm babies. It is very rare in term infants, but it can occur. And if it occurs in term baby, usually it occurs early. And it is very severe. And the hallmark is blood in stools. Blood in stools. Bleeding per rectum. And then the baby will have distension, feeding intolerance, abdomen is very tense and tender, and then the pneumatosis in the X-ray. So, do you still think this is necrotizing enterocolitis? No, it is not. Is it pyloric stenosis? What is the classical presentation of a baby who has pyloric stenosis? What is the classical scenario? It will not cause bilious fount. Yes, this is one of the issues. What else? So the classical scenario in the pyloric stenosis is that usually it is a boy, most of the time, like term, or preterm, or borderline preterm, usually presents in the 2nd to 3rd weeks, up to 12 weeks. And the baby is having emesis, but it is not bilious because the obstruction is above the drainage of the bile in the gut. And clinically, you can notice hypermotility and antiperistalsis of the stomach. The baby becomes dehydrated, and then the stools become scanty, constipation, and maybe pellet-like stools. And the baby will go into dehydration and will go into hyperkalemic, hyponatremic metabolic acidosis. Hypokalemic, hypernatremic metabolic alkalosis. Correct me if I'm wrong, because maybe I forgot. But this is the case, the scenario in congenital hypertrophic pyloric stenosis. So it doesn't fit. So it is mid-gut volvulus. Why it is mid-gut volvulus? Yeah, okay, thank you. Hypokalemic, hypochloremic metabolic alkalosis. Yes, correct. You are correct. Yes, thank you very much. So why it is a volvulus? The key is here, 12 day. Because the mid-gut volvulus could be on and off obstruction. And the obstruction occurs when there is volvulus. And the volvulus occurs any age. Any age could present as early as possible, as first day or 12th day, or even after that. Many weeks or months. So the 12th day is the key, because it will rule out the atresia, which should present early. It does not look like necrotizing enterocolitis also, as we mentioned, doesn't look like pyloric stenosis. So we'll go rapidly. So the correct answer is mid-gut volvulus, which is a severe form of needing expedient diagnosis and treatment, because if you don't diagnose it early, there will be intervention with the intestinal blood flow, and there will be ischemia and loss of the ischemic part of the gut, which is extremely serious. What is the gold standard? It's an upper GI contrast. You do gastrography in upper GI, and what are the classical findings? You will find that you see this corkscrew sign. corkscrew البتاع الفتاحة اللي بيفتحوا بيها ازايز الشامبانيا. لو انت بتشوف افلام عربي ولا افلام اجنبي، بتلاقي بتاع كده ملولوه كده، يحطها في الفله اللي مغطيه الازازه ويلفها يلفها يبقى في هنا تويستنج زي ما انت سيادتك شايف اهو حوالين نفسها، اسمها كورك سكرو ساين. The other sign is that the junction between the duodenum and the duodenum and the jejunum never crosses the midline. Never crosses the midline. It is to the right, and it is displaced downwards and to the right. Okay? And if you do ultrasound also, you can see the correlation between the superior mesenteric artery and vein, but I don't know, they didn't mention this in this critique. So upper GI is diagnostic. So what if you do upper GI and this baby, even without contrast, and this baby is duodenal atresia? What you're going to see, you will see the double bubble appearance. And of course, we have many radiological signs and ultrasonographic signs for pyloric stenosis. But the gold standard is to do upper GI with a contrast gastrography. And this is an emergency, and you should send this baby to surgery immediately. Stat. Okay. The infant in the vignette has a one-day history of poor feeding associated with bilious emesis, raising suspicion. So bilious emesis means upper GI obstruction. And upper GI obstruction could be due to many problems, including volvulus malrotation and duodenal atresia. The early signs of shock, as we saw in this baby, tachycardia, delayed capillary refill, high lactic acid, very poor prognostic sign, poor perfusion, underlying mid-gut volvulus. Diagnosis may be confirmed by an upper GI contrast and abnormal positioning of the duodenojejunal junction, which is displaced down and to the right, does not cross the midline. And corkscrew sign, as I showed you, the corkscrew sign. Also, ultrasound could be helpful, but the gold standard is upper GI with contrast. Incidence is 1 per 6,000, and mid-gut volvulus is the most severe complication of intestinal malrotation. We know that in utero, that at some point early in gestation, the gut will be outside the body and it will rotate. There is physiological herniation, and then two processes will occur. Rotation of the gut, it will rotate around the superior mesenteric artery at 90 degrees horizontally, and then 180 degrees, sorry, it's not, I mean counterclockwise, 90 degrees counterclockwise, عكس عقرب الساعة, and then 180 degrees برضو counterclockwise عشان تعرف تخش وعشان يبقى في redundant mesentery وعشان يحصل ما يحصلش malrotation. If this does not happen, this is the cause of malrotation, and this will cause on and off obstruction, which is the volvulus. And if not diagnosed and treated, there will be intervention with the blood supply. After this process, this is what normal, this is the physiology. Location of the duodenojejunal junction is in the left upper quadrant. This is the normal. Ileocecal valve is in the right. Or if you do barium enema, which we don't do now, or gastrographin enema, normally the ileocecal valve is in the right lower quadrant. If there is a mid-gut volvulus, it will be high. It will be high. Okay, it will be above the normal position in the lower right quadrant. And normally there should be a wide mesenteric base, unlikely to twist. That's why mid-gut malrotation will lead to volvulus, because it will rotate on itself. And the corkscrew sign means that the intestine is twisted around itself, and this causes the obstruction, and this causes intervention with the blood flow. So plain X-ray of the abdomen has limited value in the evaluation of mid-gut volvulus or malrotation. And if the baby is late in intestinal obstruction, it might show some proximal air fluid level. But if you wait till you get air fluid level, you are losing your baby. Okay. Also by ultrasound, as I mentioned, and you look at the position of the superior mesenteric artery and vein. And there should be treatment, emergency exploratory laparotomy. And they did what they call that procedure. They try to return the pathology to normal physiology. And duodenal atresia, usually duodenal atresia is associated with other problems. The most common cause is Down syndrome. If you have a baby with Down syndrome and is not feeding well, you have to rule out, or have bilious emesis, you have to rule out duodenal atresia. You do plain X-ray, double bubble. You do upper GI, double bubble. And also it's an emergency and needs surgery. Double bubble sign. And then necrotizing enterocolitis. This is not the scenario at all because this is a term baby, started at the age of 12 days. The baby didn't have blood in his stools, and it's totally different story. And pyloric stenosis, usually between 2 and 12 weeks, does not present in, that early, and it's usually the persistent vomiting and hypokalemic, hyponatremic metabolic alkalosis. And we are done with this question. Any comments or questions? Any comments or questions? Okay, let's proceed to the third MCQ. Okay, this is a 1 hour old baby, 26-weeker, is intubated because of severe respiratory distress. They did X-ray, which shows underinflation of the lungs with ground glass opacities and air bronchogram, meaning RDS. Exogenous surfactant is given, and mechanical ventilation support is initiated using pressure-limited ventilation. The ventilator graphics depicting the pressure volume loops before and after surfactant treatment. I gave you like a series of lectures about assisted ventilation of the newborn, which I might do it again. And one of the important issues that you should know is the graphics, the ventilator graphics that you see when you are having a baby on the ventilator. And the graphics are two types, either curves or loops. And the loop is two curves. When you do two curves, it will make a loop. And the curves and loops correlate pressure, volume, and flow. Each one of them against the other will give you a curve, and then you'll have loops. You should know the meaning of every and each loop and how you interpret it, because it's extremely important. It can tell you if the baby is doing well on the ventilator or not, if the baby needs weaning and is very close to extubation or not, if the baby needs more support. If the baby is extubated, you can tell from the graphics. So please, 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 either you go back to my lectures or I will do it again, but you have to know the ventilator graphics. So this is a curve, and this is a loop. So we have a loop showing the relation between the volume change and the pressure changes in this baby before and after giving surfactant. So what happened when you look at this pre-surfactant loop, comparing the pressure and volume during inspiration and expiration? This is inspiration and this is expiration. This is volume, this is pressure. Volume, pressure. Before, after surfactant. What happened? What is the major change that you can see from this loop? Yes, improved compliance. What is compliance? when you compare volume with pressure, what is compliance? Distensibility, yes. So how much you increase the volume per unit of pressure? If the compliance is bad, you see changes with pressure causes very low change in volume. But when you give the surfactant, the compliance improved, meaning higher volume with the same amount of pressure. And that's why the loop is this shape compared to this shape. Okay, but this is not the question. The question is, of the following, the surfactant protein most responsible for the observed change in the pressure volume curve after surfactant treatment is surfactant protein A, B, C, and D. So this will take us to the function of the different subtypes of surfactant.
B.
B. Yes, it is B. It is B. The other surfactants either have different function, like immunology function related to infection or sepsis, but they are not related to improving the compliance. How does surfactant improve lung compliance?
هو بيقلل السيرفيس تنشن.
It lowers the surface tension. So the alveoli, instead of being collapsed in RDS, they become air-filled, and they respond more to the pressure by giving higher volume of the alveoli and of the whole lung. So this is the main mechanism of the surfactant protein. B. So pulmonary surfactant is a complex substance. It forms a monolayer of the alveolar air fluid surface interface. So it reduces surface tension and prevent lung collapse during expiration. This is the main function of the surfactant, whether normal or exogenous, that you give to babies who are preterm and having RDS. Surfactant, it should be like الماء والهواء, but unfortunately, it is not available in many cases or most of the cases in your NICUs. I don't know why. I cannot imagine that a NICU can survive without surfactant. It's not fair to deal with preterm babies and you don't have surfactant. However, surfactant protein B, this is the most important component, is a hydrophobic dimeric protein. It plays a crucial role in reduction of surface tension. How? It promotes the spreading and stability of the surfactant phospholipids at the air-liquid interface and improve lung compliance. Okay. Also, it helps to package the surfactant within the lamellar pods. One of the parameters that they use to check to know how mature is the lung, and this is the more the lung, will produce
بعد إذنكم يا جماعة الصوت وإلا هعمل ميوت للكل.
the more the lung will produce surfactant. So lamellar body is one of the signs that indicates lung maturity, and also it processes surfactant protein C. So B will process C and C will help B. The pressure volume loop illustrates the relationship between lung pressure and volume during a single breath, during inspiration and expiration. Neonates with respiratory distress syndrome have a flat, close to flat loop flat. Okay. Volume curve due to low compliance. The slope of the curve increases after treatment with surfactant because compliance is improved. And this is more explanation of the loops before and after giving surfactant. Okay, any questions, any comments? Any questions, any comment? Okay. I'm sorry we have to stop at this point because I think 1 hour is more than enough. It's a heavy dose.
ألف شكر يا دكتور إيهاب.
Sorry?
ألف شكر يا فندم.
لا تحت أمرك.
شكرا يا فندم.
So we are going to stop at this point. Inshallah, we will meet not next Wednesday, but the Wednesday after. The Wednesday after, which will be December 10th.
10 ديسمبر إن شاء الله.
10th of December. And I believe it's going to be Dr.
افتهال إن شاء الله. GERD in preterm.
Yeah, gastroesophageal reflux disease. And I will contact her and we will do the presentation, inshallah. She will do the presentation, inshallah, on December the 10th. بالنسبة my YouTube channel, I'm working on that. It will be either live at some point, and for live means there should be chatting between me and you, or it will be recorded, and this is what we're going to start with the recorded videos, and I will let you know about whenever there is a video. I will let you know about it, and we already have the name of the tube, and we have the link. Any questions, any comments? I will be happy to hear before we.
حضرتك قلت يا دكتور إن حضرتك كنت عامل ميكانيكال فنتيليشن.
Yeah, no, it was assisted ventilation of the new. We started from scratch, from the embryology, physiology, pulmonary mechanics, gas exchange, and then how to administer oxygen to the baby, either by invasive or non-invasive. It was a very, very long series of lectures. It was given like maybe 2 years ago, and I still have the PowerPoint, and I can do it again. But the problem is, as you see, we do only 1 hour every 2 weeks. So, which is not enough. That's why I thought to do my tube, so to make more videos, because this, although this is a big dose for 1 hour, but it's a very small dose for 1 month. But we'll work.
تمام إن شاء الله يا دكتور.
Work on that. Okay. Thank you very much. And I'm very happy and pleased to be with you, and see you inshallah after 2 weeks.
إن شاء الله يا دكتور على خير بإذن الله. شكرا جزيلا لحضرتك.
تحت أمرك.
شكرا دكتور أكرم.